I am going to speak to you today about the Erector Spinae block, Erector Spinae plane block, and other paraspinal techniques. And, the only disclosures I have, which one is this, are that I currently have an intellectual interest in the ESP block. So if there is some bias in that point of view, I apologize for that. But I will start by saying that we're going to be diving deep into the lower levels of evidence in this talk, because we really are at the stage where our conclusions are coming from extrapolations from basic science, case reports, and frankly from anecdotes. But be that as it may, I think this is a potentially exciting area. And I am going to start with the Erector Spinae plane block, because for me that's where my interest in this area was started. And we're early enough in the stage of this that I will tell you the story of how it all began. So this chap here is Mauricio Ferrero, who is a Colombian, yet again another transplant into Canada. He worked in McMaster in Hamilton. He does a lot of chronic pain, and he had a 67-year-old patient who presented with a 4-month history of basically 10 out of 10 neuropathic pain that was radiating from the posterior spine into the anterior chest. And it was located mainly over the T5 dermatome, but was also extending inferiorly over the chest. And when he examined him, one of the things he thought he could discern was that the patient had a trigger point over an area just lateral to the T5 spinous process, about 3 or 4 centimeters lateral. He was wondering what to do to provide some relief for this patient. The diagnosis that the patient had arrived with was perhaps post-herpetic neuralgia. Some imaging had been done, which showed nothing. He didn't actually have any lesions, but that was the only thing that people could think of. So what Mauricio decided to do was kind of operate, as chronic pain physicians do, on the edge of evidence. A trigger point injection. I have great respect for my chronic pain colleagues, but they will frankly admit that, evidence is a little bit short in the chronic pain field. But he decided that he would do a trigger point injection and kind of simulate a serratus plane technique. But because the pain was so posterior, he decided to do his injection posteriorly over that area that appeared to be a trigger point. And this is what he did initially. Because he was doing what he thought was a serratus plane technique, he actually put his needle just superficial to the erector spinae muscle lateral to the spinous process. So the first injection was actually a superficial one to the erector spinae muscle. He was very, very surprised to notice that quite quickly there was a complete resolution of the patient's pain, and that was associated with a loss to pinprick sensation over T2 to T9. And the patient experienced a duration of analgesia that lasted some 36 hours. And when the pain did recur, it occurred at a much lower intensity of 3 out of 10. He then repeated the block actually a couple more times on subsequent clinic visits, and finally inserted a catheter so that he could do top-ups. And this was when he contacted me and said, what do you think about this? How is it working? I'm getting these great results, but I can't quite explain it. And one thing he did do was inject some dye and perform some fluoroscopy, and he could see the spread of local that you see over here, going up and down. So what we thought at that point was, given the fact that it perhaps was post-herpetic neuralgia, we were wondering whether this was just anterior spread of the injectate to the lateral cutaneous branches. What we then decided to do was investigate a little bit further. So the next time the patient came and we had the block again, we decided to perform a CT. And what this showed was that there was actually no lateral spread of injectate, as we previously surmised. It was all concentrated in that paraspinal gutter. But fortunately or unfortunately for the patient, what we also discovered as a result of the CT scan that we were doing for scientific investigation was that the patient actually now had an apparent lytic lesion of the 5th and 6th ribs, and it turned out to be a metastasis from bladder cancer. And this was actually what was causing his pain. It wasn't present when he was first scanned a few months prior. But again, this led us to think that now, again, more evidence that this cannot just be a block due to cutaneous branches, because, how else do you explain analgesia of rib destruction? It must be something working deeper. So we then reached out to yet another friend of mine. Sanjeev Adhikari is an associate professor in Hershey, Pennsylvania, which is famous for more than just chocolate. It's an excellent medical center there. He has a great lab with cadaver studies, and Interesting enough, this is 1 year ago, May of last year in Hershey, that the three of us gathered and did some experiments on some fresh cadavers there. And what we found was that when we were injecting superficial to the erector spinae muscle, like we did in that first case, it mainly stained the posterior surface of the muscle, as you might expect. There was perhaps a little bit of tracking through a plane that exists between the components of the erector spinae muscle, which are longissimus thoracis and iliocostalis. But really, it was when we performed the injection deep to the erector spinae that we got penetration that seemed to reach the neuroforaminal areas and stain the ventral rami. And in subsequent clinical cases that were done, we've confirmed since that this is the optimal plane for injection. So really, although we describe superficial injection in our report, deep to the erector spinae muscle is where it should really be performed. And this is an image from one of the cadavers that we studied. You can see that there is staining around the transverse processes. And we stripped off all the muscles here, and it's kind of bathing the foraminal areas. Because it is quite close to the midline where the spinal nerve root comes out, we actually managed to catch the dorsal ramus, which arises up through the erector spinae muscle, but we also get the intercostal nerve of the ventral ramus quite close to its origin, which explains why it covers both the lateral cutaneous and anterior cutaneous branches. So it culminated in the publication of this report, which came out in September, October of issue of RAPM. It describes the evolution of our technique. We present, including that sentinel case I've just described, another case of chronic thoracic pain, and 2 cases of postoperative analgesia after video-assisted thoracoscopy, as well as results of a cadaveric investigation. And this is a CT scan reconstruction of a fresh cadaver in which we performed the injection. And you can see that an injection at T5 basically spread all the way up to T1 and down to T8. And you can see that there's also tracking into the intercostal spaces, which perhaps accounts for some of the effect. So essentially what we seem to have come up with is a single injection technique that results in extensive cranial caudal spread. And because, again, it's performed quite proximately close to the neuraxis, it results in extensive posterior-anterior coverage of the spinal nerve. Now, we then sort of publicized this as a thoracic block, but it began to occur to us as we studied the anatomy a little bit more closely that the erector spinae muscle actually extends from the cervical spine all the way to the lumbar spine. And it therefore seemed logical to us that instead of just confining our injection to T4 to T5, if we were to perform our injection a little bit lower at T7 to T8, we could conceivably affect the lower thoracic spinal nerves that supply the abdomen, basically T6 to T12. And again, we investigated this starting with a fresh cadaver. And again, we were able to show that dye injection performed at the T7 level was able to spread from as low as L2-3 and all the way up to as far as T2. So confirming our suspicions that we could actually bring our target coverage down into the abdominal area. One of the populations in which we tried this was laparoscopic ventral hernia repair, which can be a very painful operation because it involves the tacking of this large mesh that you see here into the abdomen through some transfascial sutures. So patients often require a PCA, or at least they do in Canada and the US. We reported a small series of 4 patients with the cadaveric data that I showed you in anesthesia. 3 of these patients had it done laparoscopically. 1 actually had to have a conversion to open. And in this particular patient, she's one of my patients, there was actually a sensory block that, again, went all the way from just the xiphisternum down to the pubis. These patients had good pain scores in recovery for the early phase. At least 2 of them were done as day case surgeries and went home on just a little bit of oral oxycodone for the first day and some paracetamol. The other 2 stayed in for various medical reasons. But all in all, they showed some excellent pain control and low opioid consumption. This was actually something now that's just come out. I was made aware of this. Is a paper from India, a patient with a very, very impressive ventral hernia who underwent an open abdominoplasty and repair of the hernia. They actually put catheters in this case, both catheters inserted at T6, loaded it with 20 mils, and then connected it to an elastomeric pump and a Y connector, and ran a very dilute ropivacaine solution with a little bit of fentanyl. And this patient experienced excellent pain control, pain scores of 2 out of 10 throughout the length of stay, with just 2 doses of IV paracetamol throughout a 72-hour period. And they kept the catheters for 4 hours. So again, an illustration that the ESP can work very well for quite major abdominal surgery. What I found interesting, though, was that they also delivered a mil of contrast into the catheters just to see what the spread was. And you can see again, and I'm really impressed that with just 1 mil, you can get quite pronounced physical spread of that injectate. And you can see it how it runs sort of parallel to the vertebral column, presumably, again, acting in that area close to the neuroforamina. We don't know if that's penetrating into the paravertebral space. You would really need a lateral view for that, but it confirms some of our suspicions that this is where it's acting. It's hard to know, as I said, if there is a visceral component, because most surgery involves both somatic and visceral, but we do a lot of bariatric surgery in our case, and quite often our bariatric patients have a lot of postoperative pain. Partly because we're very ginger with the opioids intraoperatively so that they have a good emergence. And what happened to me one day was that one particular lady had tremendous pain, but she was getting extremely somnolent with opioids, yet, in the drowsiness, she was complaining out of 10 out of 10 pain. And I actually did quadratus lumborum blocks as our initial rescue, which I'm sorry to say, Jens, wasn't very successful, and perhaps that's just me not doing them very well. But that was the point at which I said, well, why don't we try an ESP? And to my surprise, again, pain went from 10 out of 10 to 1 out of 10 quite quickly. And so we did a few more cases of bariatric rescue, which we then wrote up and reported here. And to me, this is the sort of clearest evidence I have right now that there is some sort of visceral analgesia being provided by the ESP block, because these patients were complaining of deep pain. It wasn't the laparoscopic incisions. You'd press on those incisions and they wouldn't say it was painful. It was all coming from inside. And so I've done quite a few of these now, mostly as rescues. We may try and see about doing it preemptively, but it does seem to work in this area. The duration, however, appears to be a little bit variable. Some of that may depend on what you put in, but we've seen durations that go from sort of as little as 2 hours to sometimes 6 or 8 hours. But often, again, it appears that once you break the cycle of severe pain, it's usually quite manageable thereafter with acceptable doses of systemic analgesics. So, given all that, now we're still trying to come to grips with how the ESP block might work. And at this stage, I would really say it's how we think it works as opposed to how we know it works. Part of this, I'm going to digress a little bit because I think this is a very interesting paper that was published by some colleagues in Ottawa, Kostach colleagues. It came out, again, it's just a letter to the editor in anesthesia. And they do a lot of paravertebral blocks. But what they observed was that if they injected above the costotransverse ligament, a lot of the time they were still getting a good effect. So they did a cadaveric investigation, and they found that if they injected just posterior, which is superficial to the costotransverse ligament. So, normally we would want to be there, which is where the the paravertebral space is, and see the pleural deposit. They were actually injecting in the muscle just above that. And they were doing, they did this investigation as single, multiple injections at each level between T2 to T7 in a cadaver. And this is what they found. Despite injecting above that costotransverse ligament, they got this dense staining. This is the anterior surface of the posterior wall. You can see this dense staining all along the paravertebral space in the vertebral column, extending out into the intercostal spaces and catching the sympathetic trunk as well on both sides. So what they concluded was that the superior costotransverse ligament doesn't appear to be a barrier to local anesthetic diffusion as we might previously have thought. And ultimately, combined with serratus plane blocks, with the erector spinae plane block and this, I think what we can certainly conclude is that muscles and connective tissue are a lot more porous than we think. This is a little video of a cadaveric study from some people in Argentina who are, and I must say the Latin Americans are very, very active in this respect. I just want you to look at this area down here as they inject into an erector spinae plane. And you will actually see that local kind of runs down anteriorly towards the vertebral column, suggesting that there are actually these little channels in the muscle, perhaps the same channels that the nerves are actually ascending through as well. So at this time, we believe that the ESP may work by spreading, number one, laterally into the intercostal space, and possibly anteriorly into the paravertebral space, affecting particularly the rami communicantes that supply the sympathetic ganglion and thus exerting any visceral analgesic effect. It's also important to note that for sure what we do catch is the dorsal ramus, which supplies all the area of the back, which means that this is a block that would be suitable as well for any surgery on the dorsum, quite distinct from any of the previous truncal blocks that have been described. And because we are tackling the ventral ramus quite close to its origin, we're going to get the laterocutaneous branches and the anterocutaneous branches. So unlike a tap, which might be done there and might miss the laterocutaneous branches, we're actually managing to get all of this, which explains, you remember that first case, that extensive zone of sensory loss that went from the midline of the back almost all the way to the midline of the front. So currently, how do we advocate performing the ESP block? You, again, like Jens with the TQL or the tequila block, you have to access the back. So the patient can be placed in either the sitting position, the lateral position, or the prone position. The lateral position is particularly useful for post-op rescue blocks. If you are working in somebody who's fairly slim, or if you're in the upper back particularly, you can use a linear transducer, but I do find that a curve sometimes helps in the bigger patients, and particularly in the mid to lower spine, because they tend to have a little bit more muscle over there. You can start with a transverse, which will help you to identify exactly where the spinous process is. So the spinous process and then the transverse process. So in the thoracic area, it dives down to this valley of the lamina and rises up to the TP, and then the rib a little bit more laterally. So with that, you can more precisely ascertain exactly where the line of the tip of the transverse process is. However, we currently advocate having the probe in the longitudinal position for the actual injection. And with that, you will see the hyperechoic shadows of the TP. You don't often tend to see the pleura because it's diving and curving away. But if you're up in the upper thoracic region, we will usually see 3 layers of muscles, the trapezius, the rhomboid, and the erector spinae. But really, this is the only one that you kind of need to be focusing on, the muscle layer above those bony shadows. If you come down to the T8 level, rhomboids terminate, have the lower edge at T6 or so. So once you're down below that, you're not going to see 3 muscle layers. You're just really going to have trapezius and erector spinae. But once again, the focus is on identifying the bony shadows and the muscle that overlies them. And this just illustrates that the rhomboids end up here, and we're already operating in this area in the T8 area where you don't see that layer. Now, if you are a little bit too lateral over the ribs itself, the picture's a little bit different. You will see the pleura. The ribs have a slightly different contour. Now, a few months ago, we would have been sort of quite rigid and said, yes, you have to be over the transverse process. You do want to be over the ribs. Based on some of the stuff I'm going to show you in later slides, I'm beginning to think now that it doesn't matter too much as long as you are in that sort of transverse process rib area. The effects are probably going to be similar. However, if we believe that we get some of the effect from penetration into the thoracic paravertebral space, I don't think you want to be too lateral when you perform this injection. So right now, I would still say try and make sure you're over the transverse processes rather than far out over the ribs. A few small tips that we found useful. You want to use a fairly shallow needle trajectory. Contacting the bone is a useful guide to not going too deep. We advise contacting the sort of far edge of the transverse process because occasionally you may need to slip just a touch deeper to find exactly the right plane. Nevertheless, for the novice, striking the transverse process is a very sort of comforting endpoint. You often have to withdraw very slightly so that you're not embedded in the periosteum of the transverse process. But ultimately, what we're trying to do is to see this linear spread of fluid that lifts the erector spinae off the transverse process. That is our endpoint. And once you see that, we put, as Jeff Gadsden would say, one standard local anesthetic unit of 20 mils in an adult patient. And you can also thread a catheter in for subsequent boluses. This is a video that shows it being done. So the needle's coming in. It's going to contact that transverse process down here. And as we come in, you do a little bit of injection. It's best to inject with a little bit of inactive fluid, such as dextrose or normal saline, to confirm that you're in the right place before you actually deliver your bolus of local anesthetic. So occasionally you can be within the muscle, and if you see that distending, you want to go a little bit deeper. But as you can see here, what you really want is this big sort of linear spread of local that floats the erector spinae up off the transverse processes. And here's a catheter that's lying in place along there, and it threads very, very easily because that plane opens up quite nicely with the fluid bolus that you give. This is a video in a slightly bigger patient, one of the bariatric patients. So we've got a curved probe set to 9 centimeters. You can still see the transverse process there, needles coming in, and as it contacts, again, all we're looking for is for expansion of the local to, again, lift up. As you can see right there, it opens it up and lifts it up. I don't do pediatrics myself, but again, reports are coming in, particularly from Latin America. This again comes from Argentina, where they're embracing this block quite enthusiastically. There is a compelling risk-benefit ratio here because you don't have to go near the neuraxis in a sleep child, which I think appeals on many, many levels. Again, I don't do lots of pediatrics, but this apparently is a sign of a very, very comfortable child who's got an ESP block and an ESP catheter immediately after a thoracotomy. I would say at this point, based on communication with them, obviously a linear probe is suitable. You want to be careful then in pediatrics with the total mass of local anesthetic. We're not quite sure yet what the optimal dose is, but what they certainly suggest is that because it's so easy to see stuff in kids, that what they've been doing is actually tracking spread of local in real time with their probe as they inject. And once it goes over the desired number of transverse processes, that's when they stop injecting. And they've been able to do that with as little as 0.2 mil per kilo of local anesthetic. And again, the catheter lying in the space just there. And you can see it going all the way down with the local spreading over multiple levels. Every day it seems that we get a WhatsApp message about people using the ESP block for different procedures. So we talked about thoracic and abdominal, but the Japanese group of Urshima and Otake, who actually also publish a lot on other truncal blocks, recently put out this paper describing the erector spinae block for thoracic spine surgery. So surgery on the actual vertebrae, spinal stenosis in one case, and a vertebral collapse in the other. And as we said before, really we're getting this dorsal ramus, so you're getting very profound anesthesia of the back. So it is logical that the ESP block would be something that's suitable for spine surgery as well. And again, I think this is something that's very, very promising, and I expect to see more in this area shortly. I want to digress a little bit and tell you this anecdote. Some of you may recognize this man from his picture, and even if you don't recognize his picture, I'm sure you're familiar with his work. That's Charles Darwin and his publication on the origin of species and the theory of natural selection. But I bet most of you don't know who Alfred Wallace is, and I certainly didn't until I read about this. But he was a young naturalist working in the Far East, on the other side of the world from Darwin, who one day wrote to Charles Darwin and said, you know, what do you think about this paper on natural selection? And he had quite independently come up with a theory of natural selection. And Darwin, as you might imagine, was a little perturbed by this because he'd been putting it off for 20 years before writing it up. But happily enough, they came to this amicable conclusion of publishing the first paper on the theory of natural selection jointly. And Charles Darwin subsequently went on to describe his seminal work. But the story doesn't really end there, because it turns out that in the year that Charles Darwin first set off on his voyage to the Galapagos in the Beagle, this chap, a Scottish gardener, the Scots are very clever people, Patrick Matthew, he actually described the principles of natural selection. Unfortunately, what he did was publish it in a very brief appendix to a book, of all things, on naval timber and arboriculture, which, as you can imagine, did not attract a very wide audience, and thus went unnoticed. And it was only after Charles Darwin put out his book that Patrick Matthew got all sort of upset and said, you know, you stole my idea. And actually, to this day, if you go on the website, there is a whole website devoted to saying Patrick Matthew should be recognized as the father of the theory of natural selection. But I really tell this story to illustrate that new scientific ideas can occur quite independently to different people. And, you know, I will say that although we described our block as a novel analgesic technique, I was made aware, through Twitter no less, that just a few months prior, a French group led by Cédric Rouet had published something called the Intercostal paraspinal nerve block for thoracic surgery, and they had described injection over the ribs just deep to the paraspinal muscles. And you can see here that essentially it looks very, very much like our erector spinae plain block. And they describe that same staining of the deep surface and the intercostal nerves. But if you dive even further and rewind to 2010, what we find is that a surgeon, no less, had actually come up with this idea even before we did. In this paper, they talk about describing a novel technique for placing catheters in what they call the extrathoracic paraspinal space, to provide continuous intercostal nerve blockade for rib trauma. And you can see here what they do is they use a proprietary OnQ multi-hole catheter set with a tunneling device. They cut down onto the rib and then they insert this tunneling device up and down along the spine here, and placing it just superficial to the rib. So they use some different terminology to describe the anatomy of the space, but essentially they are doing what Rouet had described and what I guess we had described as well. They followed that initial description up with a report of a prospective cohort of 100 patients, all of whom had at least 3 unilateral rib fractures. They put 2 catheters on each side, one from the top, one from the bottom, infused it through these 2 devices, and showed as you can see here, quite a significant response in terms of reduced pain scores and increased respiratory capacity. And the patients were much more comfortable and able to leave hospital early. Diving into, again, their description here, they talk about the insertion site being about 3 to 4 finger breadths lateral to the spinous process. So once again, I think even though they call it intercostal nerve block, they are quite close to that transverse process the transverse process rib junction, and therefore I think it's very, very similar to the ESP block. I also found it quite amusing that they actually described using ultrasound as an adjunct in obese patients. So perhaps one case where the surgeons have been ahead of us. More studies have actually come out on this. And again, you know, perhaps because it comes out in less recognized journals and, you know, the titles being used don't draw our attention. But this is actually interesting because they compared intercostal, or what they call now the intercostal nerve block, with epidural analgesia. It was a retrospective study done in a level 2 trauma center in the US. And interesting enough, this particular hospital had completely changed practice, probably following through its description of that paraspinal intercostal block. And it switched over from doing thoracic epidurals to doing that paraspinal intercostal block. And they then looked at their data to see how it compared. And what they found was that the patients had similar incidences of pneumonia and respiratory failure. The ICU and ventilator length of stays were similar, but there was perhaps a trend to a shorter length of stay in the group that got those paraspinal intercostal blocks. And then we have yet this other group. Unfortunately, they decided to call this block something else, but really it was the same thing. They call it a posterior paramedian subrhomboidal analgesic block, which doesn't help matters when you're trying to search PubMed. But once again, they were looking at patients with multiple rib fractures. They did a prospective trial, though. Having said that, it was non-randomized. They did ask patients, do you want an epidural or do you want this new block that we're going to do? Their epidural was run at 6 mils per hour with boluses allowed, and their intercostal nerve block was done, again, with the option of doing boluses. So, similar to that previous study I showed you, again, what they found was that the two techniques appeared to be quite similar in terms of efficacy. So they resulted in similar ICU and hospital length of stays, similar inspiratory lung volumes. Again, it's a small study, so this is only a trend, but there certainly was a trend to less hypotension in the patients who got the paraspinal intercostal nerve block. This is the graph that they showed, and what was surprising too was that patients who received this block experienced a much more dramatic acute reduction in their pain scores, and there appeared to be this trend to less opioid consumption and better pain control even throughout their stay, which I think is very, very interesting. And then we have our colleagues from Darlington. I'm pleased to say Bhaskar is also an alumnus of Toronto Western, but doing some great work with Duncan Hamilton in Darlington, and they published the Erector Spinae plane block. I'm told that they read about it and the next day immediately performed this in a patient who had quite extensive unilateral rib fractures, 10 out of 10 pain despite multimodal analgesia and opioids. And they again decided that they would insert a catheter, loaded it with quite a large volume of bupivacaine, but the patient, I'm told, apparently fell asleep within 30 seconds of having the block, demonstrating its efficacy, and managed to maintain that level of comfort for the 4 days that they ran an infusion, quite low dose bupivacaine at 10 mils per hour. So I think that's fantastic, and they've continued to explore the ESP block and have very, very good results. So there is actually now quite a lot of literature. I think if we lump ESP and paraspinal intercostal blocks all together, there is evidence, certainly in thoracic trauma, that it's an effective technique, and there's early evidence actually for similar efficacy to a thoracic epidural. So I think that very much lays the ground for more prospective randomized compared trials. Certainly, you can see that on the surface of it, there are fewer contraindications compared to a thoracic epidural. It's potentially easier to perform. I think it's something that most trainees would be fairly comfortable. You're distant from the neuraxis, you're distant from the pleura. Unlike the serratus plane block, which has also been described for use in rib fractures, this will perhaps cover more posterior lateral rib fractures as well. And again, these are images that have been sent to me with ESP catheters, here bilateral trauma, here somebody actually having an open repair of multiple rib fractures. And this is the latest paper to have come out talking about, once again, that paraspinal intercostal nerve blockade being done in patients undergoing a NUS procedure. I wasn't really sure what a NUS procedure was, but essentially it's correction of a pectus excavatum. And as you can see here, not surprisingly, it's probably quite painful. You have a metal rod inserted into your chest and sort of hammered through. I think they are looking through a laparoscope to make sure they're not inadvertently doing a heart transplant. So as you can imagine, I think there's scope for some regional anesthesia in this procedure. And what this group did was to compare, as you might expect, epidural analgesia with their paraspinal intercostal. I found it quite an interesting paper because, again, I was telling you how we used to be quite rigid until a few months ago about being over the transverse process. You can see here that they're placing the catheter kind of in that transverse process rib area, but using, again, the technique that was first described by the surgeons, using that on-cue tunneling device. Now, I think that to be congratulated for, first of all, doing some cadaveric work, which again adds to what we already know. So once again, you see the staining of the paraspinal muscles on even its superficial surface. But as they dive deeper, you can see that it's staining the deep surface, it's staining the dorsal rami, which remember accounts for the posterior coverage of the back and perhaps explains why it might be useful even in spine surgery. And then as they dive even deeper, it's basically staining the deep surface of the ribs and the medial and lateral branches of the dorsal ramus here, but also getting down into that foraminal area just next to the transverse processes. Now, they didn't find any evidence that it was tracking into the spinal canal per se, but certainly it appeared to be around the neuroforamina. And what they postulate is that you get this kind of spread. So, as I said before, injections into this deep area around erector spinae seems to track into the intercostal area, but they believe too that it seeps up through the muscle, gets the dorsal ramus, and then sort of percolates down through what they call sort of canals that these nerves, the dorsal rami, particularly travel through. And they think that this is the mechanism by which it reaches into these deeper spaces, which I think is quite plausible, because as I've shown you now, those areas appear to be much more permeable than we might have previously believed. So just to run through what they briefly did, this is a very small study. It's almost a pilot study. They just took 10 of those 10 patients having that procedure I just showed you. 5 of them got sham catheters, 5 of them got active catheters. They put it in before surgery started, loaded it, infused it, and kept the catheters for 3 days. And what they did find was that in all the patients who got the active catheter, they were able to demonstrate a sensory loss to Cole, again, over a large area, which is, again, not unexpected given where they put the catheters. They didn't observe significant differences in the active block versus the placebo. Unfortunately, you can see here, this is the use of opioid. The yellow bars are the treatment groups, so a trend to a slightly lower opioid consumption. This is what they call a rehabilitation score, how much that the patients could do. Again, patients seem to be able to mobilize a little bit better if they had the active block. There was some reduction, as I said before, opioid use and functional rehabilitation, but unfortunately not much difference in the self-reported pain scores. But once again, this is a very small data, so there is perhaps a suggestion for analgesic benefit. Now, this was anterior surgery. Again, talking to Duncan and Basker, they have tried the ESP block for sternal fractures. It wasn't brilliant. So, you know, maybe anterior versus sort of lateral coverage isn't good. Like I said, I think we're still feeling our way with these blocks. But the last technique I want to cover in the 5 minutes that remain to me is yet another technique called the retrolaminar block, which I think too has been sort of overlooked up in the run-up to all this. And this again is described by the Germans back in 2005. Unfortunately, again, it was in the German paper, which again may account for the fact that it went unnoticed. But essentially, instead of doing a paravertebral and getting to this space, they really decided to just land on the lamina and inject. But once again, the key is that they're injecting deep to erector spinae muscle, but they're now doing it a lot closer to the midline. Some people did pick up on it, and as you might expect, before too long, somebody described an ultrasound-guided version of this. Before that, it was just landmark. In this quite nice little paper, they actually showed you the different ultrasound images that you get as you progress from out lateral over the ribs towards the transverse processes. So this would be the image that we might use in a ESP block, and finally to the lamina, which is where they actually place their needle and the catheter. And again, they'd studied this in rib fractures and found that it was opioid sparing and that it appeared to be beneficial. We have got one randomized controlled study recently, again published by the Japanese, looking at the retrolaminar block versus paravertebral blocks in modified radical mastectomy. Both of the techniques they used were landmark guided at T4. And what they found after injecting 10 mils, advancing a catheter, and loading and running an infusion was that patients in the retrolaminar group pressed the bolus button on the infusion device more frequently. That was really the only difference, okay? And you can perhaps explain that by the fact that because you're a little bit distant to where the paravertebral space is, you perhaps need to use more volume to get a similar effect. But otherwise, in terms of analgesia, none of the patients in either group really needed opioids. A few patients in the retrolaminar group needed non-steroidals, but it looked like it provided fairly comparable analgesia to a traditional paravertebral block. They also did a little bit of cadaveric work. They found that the dye didn't seem to go into the paravertebral space in a cadaver model. So at this time, they didn't think it was truly the same as a paravertebral. Now, I will say that at this point, I think cadaveric work has its limitations. I think personally that spread in the living subject is going to be more extensive. So anytime I read work about cadavers, I'm going to say that you have to take it with a pinch of salt. It may not fully explain what actually happens in patients. Finally, there are actually a couple more paraspinal blocks that have been described. One is the rhomboid intercostal block, and then again, another letter to anesthesia, and a French article calling the trapezoid rhomboid block. These two, I think, are a little bit different because they actually target areas quite lateral to the spine, out near what's called the triangle of auscultation, where the trapezius border meets latissimus dorsi. And I think that's significantly different enough because now you're probably not going to get spread into the paravertebral space. So to sum up, I think we have basically three groups of blocks. One would be the retrolaminar, which is performed quite close to the midline. Then we have, the erector spinae plane block, and I would include the paraspinal intercostal block as the surgeons have described it into that area because really we're injecting in the same area. And then those last two I told you about, which are a little bit more lateral. And I think it is important to distinguish between them because those physical locations may account for the difference in spread. When you do retrolaminar, it is possible that you get some tracking outwards, but it's also possible that you get tracking directly through the interlaminar spaces into the canal. And that's something that we're trying to investigate and compare with the ESP block. I think if you do it far out laterally here at the edge of rhomboid, then you're not really going to expect to get very much tracking towards that paravertebral space. But what you should get, just as with a serratus plane block, is involvement of the intercostal nerves. Right now, obviously barring my bias, I would say that we still think that perhaps this is the sweet spot for injecting because you have the potential of both getting the intercostal nerves, but also perhaps promoting spread into that space. We don't know between these blocks whether there's going to be a big difference in the extent of the cranial caudate spread, as well as the extent of anterior spread and how that translates into efficacy. But what I think we do know is that with these paraspinal blocks, one clear advantage is that you get extensive cranial caudate spread because you're working within this plane. So if you're interested in a single injection technique, I think it's great. If you have to inject distant to your surgical site, it's great because you can still reach it. You can match it more precisely to the site of surgery. So compared to the QL block, which you do in the lumbar area, hoping it's going to spread up north to the thoracic area, now you can actually place your block congruent with the thoracic spinal nerves that you're actually interested in. As I said before, it appears on early evidence that there's potential for spread to the paravertebral space and thus visceral analgesia. You get posterolateral coverage of the dorsum of the back, and again, that opens up the scope of applications, I think. A catheter is also easily inserted, and I think that's quite key because there does appear to be limitations in terms of duration. Finally, it's relatively safe. Every time I offer a rescue block to a patient and tell them I'm going to stick a needle in their back, they always ask whether it's a needle in their spine, and it's actually, you can almost sense their relief when I say, no, we're not actually sticking your spine just into the muscles of your back, which is actually what we're doing, and they say, fine, that's okay. But if it was literally telling them that we're going to do an epidural, even the paravertebral, I suspect many of them would refuse. At this time, as I said, because we're injecting distant to the sites of interest, it's going to be variable in intensity, it's going to be variable in duration. So I would suggest inserting a catheter wherever possible. Some of that offset in duration may be due to vascular reabsorption. So I'm going to say that last is a real risk. So I would always add adrenaline, and I would respect the maximum local anesthetic doses that you inject and always monitor your patient afterwards. And theoretically, though, there are minimal risk of these complications compared to the more neuraxial techniques. We don't know yet whether it will result in less hypotension, but one would expect so. So lots of unanswered questions at this time. I think this is going to be an area of exciting research going forward, and I would say we can look forward to a very interesting time. This is an editorial written by Amit, which just shows you that we're at this stage where this is the TAP literature that's been published since 2006. This is the quadratus and PEC literature. You can see that we've yet to take off, and the erector spinae doesn't even begin to figure here. So I think that this block has potential in terms of being easily performed by all. It's quick and simple, it's reliable and consistent. Potentially it's opiate sparing with minimal complications. Whether or not these prove to be consistently realized in clinical practice, I hope to hear from all of you and many other people in the world as your experience with that. So in summary, I think we live in exciting times, and I look forward to the journey. Thank you.